So chapter 22 deals with our respiratory tract infections. We have the upper respiratory tract and the lower respiratory tract. It's basically defined by that epiglottis as the juncture. So what is above the epiglottis includes your throat and your larynx. That's your voice box is your larynx. The pharynx is your throat. And then your mouth, your nose, your sinuses, the nasal cavity, all that's the upper. Lower, anything below that, and the trachea, in the lungs, the bronchi, the bronchioles, and the alveoli. The alveoli are the site of the gas exchange when you're breathing. All right. Our anatomical defenses. These are our first line defenses in the respiratory tract. We have nasal hairs, ciliated epithelium. So what this is there's cilia on the surfaces of your lining of your lungs and your trachea and stuff. And the cilia is constantly trying to move any debris or mucus out of the lung area. So we call that the ciliary escalator. We have mucus to trap debris and microbes. We also have coughing to help clear everything out. Sneezing helps clear stuff out of the upper, and then swallowing. All this helps with removing the microbes. When we talk about the defenses of the respiratory tract, the second and third line of defense, what do I want to make very clear about the respiratory tract? We talked about the eye and the nervous system having basically a decrease. We call it immune privilege, right? And then we have the blood, which had that's where pretty much your immune system lives. It's in your blood and your lymph, right? So we've got a heavy, just regular existence that just happens to live within the bloodstream, so it can be transferred throughout everything. But with your immune response in your respiratory tract, it has its own kind of setup, and it's not going to be an immune privileged one. It's going to be a stronger setup than pretty much everywhere else in the body, specifically because microbes that are coming in through inhalation, we need to have something set up in order to prevent them from getting into the body. So we have complement action in the lungs. We have increased levels of cytokines, which are signaling molecules, as well as antimicrobial peptides. Macrophages that are specific to the alveoli that we call alveolar macrophages. And then clusters of lymphoid tissues, such as what we have in the tonsils and the adenoids. And we also have secretory IgA. In your mucosa, including in your mouth and in your lungs, this is all mucosa. Any of your wet surfaces pretty much are your mucosa. That we have IgA that is secreted in those areas because having just IgG in your bloodstream just isn't enough for the protection. So we have IgA, which is a type of antibody that's found in the secretions of the mucosa. That helps with defense there. And we have quite a lot of bacteria and yeast that are involved in your normal microbiome. I'm not just going to list all the ones that could possibly be, but we're going to talk about some ones that might be significant. This includes Candida albicans and Candida auris, which are yeasts. Just to remind you guys, can't say it enough. And yeasts are fungi, right? So large number of bacteria, and all of this biota in our respiratory tract serves in the role of microbial antagonism that basically keeps pathogens from being able to find a stadium seat, as well as producing antimicrobial things that would prevent pathogens from being able to live in that environment and using up the nutrients and all that stuff. So some guys that can be part of the biota of our respiratory tract can even cause disease, like Streptococcus pyogenes. We know Streptococcus pyogenes because it causes strep throat, which we're going to talk about today. But we also know it because it's involved in impetigo, which we're talking in our skin diseases. And then Haemophilus influenzae, Streptococcus pneumoniae, and Neisseria meningitidis. All three of these guys were implicated in meningitis. And both Haemophilus influenzae and Streptococcus pneumoniae can cause respiratory disease. Streptococcus pneumoniae is the #1 cause of communally acquired pneumonia, which we'll talk about today. But so these guys can just naturally be part of your biome and can lead to disease in various areas of the body. Let's start off with our diseases. The common cold, technically a syndrome, okay? Technically a syndrome, because the common cold is defined by its signs and symptoms. Sneezing, scratchy throat, runny nose, usually no fever, but it might be a low-grade fever, and children might have a little bit higher fever. Infection with the common cold can predispose patients to secondary infections, often by bacteria. And usually, even those secondary infections can be related to stuff that's already in your own biome. Symptoms are not usually caused by the virus causing damage, so much as it's the immune system relating to the infection. There's over 200 different kinds of viruses that can cause a common cold. And so this is why it's a syndrome, because it's defined by the signs and symptoms, not by what causes it. Some viruses that can cause the common cold will be rhinoviruses, coronaviruses, not including COVID or SARS, adenovirus, and RSV. RSV can cause cold symptoms in adults particularly. Little tiny babies are going to have a much more serious effect with RSV. And we're going to talk about RSV specifically in a moment. We usually don't treat this with any kind of a drug or anything. We usually just let it run its course. Common cold is always transmitted by droplet contact and indirect transmission, things like fomites and stuff like that. Moving on to sinusitis. Sinusitis is usually going to be a progression of either cold or allergy, and then the inflammation caused by those things can lead to other things causing infections in the sinuses. You have 4 pairs of sinuses in your skull, and any of them can become inflamed, and that's what would lead to sinusitis. This will cause things like sinus pain, nasal congestion, pressure, headache, and even toothache from the pressure near the nerves of the teeth. Discharge is always going to be opaque, and it may be green or yellow in color. Most sinusitis is caused by viruses, and it's usually the same virus that caused the common cold when that's the case. So by far, sinus infections are going to be caused by viral infections in the sinuses, leading to the congestion and the inflammation in the sinuses. It can be caused by bacteria or fungi as well, but those are going to be far less common. Moving on to otitis media. Acute otitis media is an ear infection, usually due to inflammation of the eustachian tubes, often due to having a cold. Again, having a minor cold can lead to all these other things like sinusitis and ear infections, otitis media. And so what happens with this is the eustachian tubes that help equalize the pressure between the ears and like the throat and sinuses, usually those will be able to, when you swallow and you hear that popping noise, that like low level popping, that's your eustachian tubes opening up, allowing the pressure to equalize. What happens is that pressure will not be able to equalize due to the inflammation in that eustachian tube. And then fluid will build up in that area. That fluid that is secreted through that would be called effusion. And bacteria can build up and grow in that fluid that gets built up in there, often due to biofilm formation from the bacteria that are normally found in the sinuses and upper respiratory tract. Signs and symptoms, of course, will be fullness of the ear, maybe pain in the ear, and loss of hearing. And younger children might be irritable or have trouble sleeping or eating. This can cause the fluid to build up behind the eardrum and cause the eardrum to burst. And so rather than let the eardrum burst on its own from this, we can insert tubes into the ear to allow the fluid to drain out. So all of that infected fluid that built up behind there will be allowed to drain out of the tubes. The problem with the tubes, they're just like an open tube that just lets the fluid drain out. And so if you are going swimming, when you have tubes in your ears, the fluid, the water from the swimming can get into your ear that way. And your eardrum is meant to be a barrier in addition to helping with hearing. And so having that open water into that environment can cause worse infections and things like that. So, but it's better to have the tubes inserted, sort of like fasciotomies. It's better to cut the skin open rather than have it swell up and rip itself open. Same thing with your eardrum. Better to have the tubes inserted. Most of the time, otitis media is being caused by Streptococcus pneumoniae. Again, normal inhabitant of the body, and is associated with meningitis and pneumonia as well. Doesn't always cause those things, but when it finds its way out of in low numbers in your upper respiratory tract, it finds its way out of there. That's when it causes problems. We're also seeing more increase in numbers of ear infections being caused by Candida auris. And so this guy's pretty resistant to medications, and so this is an increasing problem. Candida species are all yeasts, and yeasts are fungi. These are not communicable diseases. They are usually going to be caused by the inflammation, and then their people's own biota overgrowing in these areas. All right, moving on to pharyngitis. Your pharynx is your throat. So this is inflammation and swelling in the throat, and it often causes pain, which is usually going to be caused by viruses that are associated with the cold, again. But sometimes it can be caused by bacteria, and when that happens, it's a more severe disease. Viral sore throats are more tame, typically, than bacterial sore throats. And bacterial sore throats can become so severe, we can have other diseases developing as a result of them. So the bacteria that are usually associated with severe sore throat symptoms are going to be Streptococcus pyogenes, strep throat, and Fusobacterium necrophorum. Signs and symptoms, you'll have white patches on the throat, you'll have difficulty swallowing, foul breath, And again, most of this is going to be less severe. With viral infections, with bacteria, you can often see fever and progression of disease beyond just the throat. This is just some images of some white patches that have developed on the throat as a result of pharyngitis. Streptococcus pyogenes, again, I know we talked about it in our skin diseases, but just to remind you guys, it's a gram-positive coccus. They'll grow in chains, strepto. What can happen is Streptococcus pyogenes has certain surface antigens on them that mimic our host proteins. So we have this up here on our top line. And it has surface proteins that look like self proteins. And so when our immune system tries to attack Streptococcus pyogenes, it ends up making immune response to self also. And this is usually transient, typically. This will be a transient thing, but whenever you have anti-self stuff happening as a result of a strep infection, this leads to scarlet fever. And if it continues to progress, you can have inflammation affecting the heart, or we will have rheumatic fever. And also, the antigen that's left behind from clearing out that infection, our antibodies will bind with it and get stuck in our as immune complexes in our little tight spaces, like in our vasculature, especially in our kidneys where we have our toxins being cleared out. And that is to remind you guys of the type 3 hypersensitivity that we learned about, acute post-streptococcal glomerulonephritis. It's a mouthful, but all that is related to how the immune system is responding to strep. Some people can actually develop almost lifelong autoimmune disorder just from having had strep. Then Fusobacterium necrophorum, another bacterial cause of pharyngitis. About 15% of acute pharyngitis cases that will end up needing treatment by doctors, will be caused by Fusobacterium necrophorum. It's gram-negative, and it's more commonly associated with peritonsillar abscesses. We call this Lemierre's disease. And what happens is we get those pockets in the tonsils that will fill up with the pus from this Fusobacterium necrophorum, bacteria growing there, pus forming. And these pockets of the tonsils grow so large that it can actually lead to potentially rupture of that tissue, as well as risk for sepsis and like meningitis and things like that coming from this bacteria. And that's when it becomes life-threatening. You usually have to have those abscesses drained medically. If you don't have tonsils, then you're less likely to have those peritonsillar abscesses, but you can still have strep throat and stuff if you don't have tonsils. You don't need to have tonsils to get that stuff. Let me tell you, because I know. All right, whooping cough. This is also known as pertussis. So when we talk about the Tdap vaccine, we're talking about tetanus, diphtheria, which we won't be talking about in this chapter, but it is another respiratory disease caused by bacteria called Corynebacterium diphtheriae, and you're welcome. You don't need to write that. But this one is pertussis, and so this is a P part of the Tdap. Pertussis is caused by a bacteria known as Bordetella pertussis. And if you know anything about any veterinary stuff, and you have probably heard of Bordetella. Bordetella is a cause of kennel cough in dogs, and they vaccinate for this for dogs. So it's the same kind of thing. It's a cough disease, but in people. This is Bordetella pertussis. It's a very serious disease. It has 3 phases. The catarrhal phase, you can kind of think of that as being similar to the prodrome. Our initial respiratory tract symptoms, where you'll just feel like you have a respiratory disease. But once the serious coughing sets in, this is the paroxysmal phase. Pertussis was previously known as the 100-day cough. And if you guys have ever had a situation where you breathe in your own spit or breathe in a drink or something, and you end up coughing, it's like, but you have to like breathe in like that, that's the whoop of whooping cough. And so these are people that have weeks long of coughing straight like that. So it's a very serious cough disease. The coughing can result, not the disease infection, but the coughing results in broken blood vessels in the eyes, vomiting, and even hemorrhages in the brain because the coughing is so severe. The coughing is actually so severe that even after you are able to clear the infection, either from antibiotics or naturally, potentially, and once the infection is gone, the convalescent phase includes having damaged your ciliated epithelium of your lungs so badly that you are now susceptible to secondary infections from other bacteria. It becomes very serious. We have a video of a little baby that has this. Well, let me see if I can. It's going to play this. I only have the speakers in my computer for some reason now. So stick with me here. So you can hear the poor little baby coughing. Here we go. Poor baby.
9
Oh my God.
Seniors agree. Medicare Advantage provides better quality care, affordable coverage.
So we got this, right? And this is pretty much what the whole video is going to be. So whooping cough is considerably more common in babies under 1 year old because they haven't been vaccinated for this yet. And so people who are older and maybe their vaccine is waning and is not working as well for them, that the older people can get this and not have a serious of disease or even be carriers of it. And they can go visit their little grandbaby in the hospital, and then that grandbaby ends up with pertussis. It's something we still have here in the United States despite the vaccine efforts, because it can just be carried pretty easily. And it's way more common in little babies, and it can be life-threatening because of the damage that is caused. Again, this is caused by the bacteria Bordetella pertussis. The small gram-negative bacteria, it's a strict aerobe, and it has all of these toxins that are associated with causing the disease. And because it's gram-negative, it also has endotoxin. So this leads to a massive inflammatory response in the respiratory tract. There is a vaccine for it that is very effective, but you do need to get boosters for it to maintain your immunity. If you're getting your tetanus vaccine every year, then you're getting boosters for this as well. Moving on to RSV. RSV is respiratory syncytial virus. It produces giant syncytia, which are whenever cells end up merging together and creating these giant multinucleated cells. That's a cytopathic effect caused by the virus. So this is airborne disease spread by droplet transmission, and it's more common in the winter and spring. We're going to talk about why that is in a little while with our respiratory diseases when we get into, I believe the flu is when we're going to talk about that. We had a significant decrease in RSV associated with masking and social distancing that was incorporated as part of trying to control COVID. Whether or not COVID was contained by masking and social distancing, it probably did decrease the number of infections that we would have seen, but it was very helpful in decreasing the numbers of RSV and influenza during that same time. And imagine if you had COVID like they did back in the beginning, plus also RSV and or flu. I mean, you can get all of them at once. So that's the thing. So we did see significant decrease in RSV. And once we dropped masking and social distancing, we've seen an uptick with RSV since then again. Yeah, spoiler alert, I guess, or disclaimer, or I don't know what if you care or not, but if you go to covid.gov, this is a government-run website that you would think would contain information about COVID and how to prevent the spread, or make you get vaccinated or something like that. If you've been following this administration, it probably wouldn't surprise you to hear it's mostly a propaganda site trying to blame China for causing COVID. I don't know. It's worth a look if you have a chance. It's one of those things that when I opened it, I thought it was just, Instagram people being whiny and, how it can get on social media. But when I went and looked at it, I was like, oh no, this is real. Okay. Take a look at it when you get a chance. It's eye-opening. I don't know. Anyways, moving on. RSV, signs and symptoms. Usually most adults that have a healthy immune system will have cold-like symptoms, appear like the common cold. People who get more serious infections, this will be related to having a lowered immune system. What we see in like little children under 6 months of age, or more commonly going to be having these serious symptoms where we're having issues with breathing. And transmission, again, it's very highly contagious from droplet contact. And fomites. And fomites would be things like this controller. If I had RSV and I contacted this controller and then you came and used the controller later on and then got RSV from that, the controller wasn't infected. You might have been contaminated, but it serves as a vehicle for transmission. This would be a fomite. Just to remind you of that term, that was a chapter 14 thing. There are antivirals that can be used for RSV to decrease the severity of those symptoms for particularly with children that are having more serious effects of RSV. Moving on to influenza. Influenza is caused by the influenza virus. We call the disease the flu, and it's always caused by influenza virus. There's no other thing. A lot of people have a misconception about that, but I will be wrong. Influenza is caused by the flu. This is not a syndrome here. And so there's different kinds of flu virus. There's flu A, flu B, and flu C, which you probably haven't heard of. Flu A by far is the more common one. We have annual flu seasons. Basically, every year we will do some testing to figure out which strains of flu are out and about, and we will create vaccines against those strains that are coming out. What we have found is that flu is very highly mutatable and creates a lot of mutations in its replication cycle. So every year when a new strain of flu comes out, they might be flus that are similar to the ones that your body has seen before, but it's not similar enough for you to be able to have full protection from the previous guys. So slightly mutated. Sometimes we have brand new flu viruses that your body hasn't seen any part of it before. And so that's what we get when we get those weird outbreaks from like swine flu or bird flu or something like that. The human race has not seen them and you have no existing immunity whatsoever for them. We'll talk about how that's made in a second. Signs and symptoms of the flu: headache, chills, cough, body aches, fever, stuffy nose, and sore throat. We don't have the runny nose as common. We usually have a stuffy nose. But that's not to say that you don't have similar signs and symptoms with the cold and the flu. The difference with the flu is you always have a fever and you're always going to have the body aches, and you will usually have an extreme fatigue associated with the flu. So those things make it characteristically different and not part of the usual cold symptoms. Oftentimes infection with the flu virus can make you more likely to have secondary infections that can lead to things like pneumonia. And of course, people who have lung disorders are going to be more likely to have serious complications from the flu. This is the flu virus. We're going to be talking about hemagglutinin and neuraminidase, which are some surface proteins on the surface of flu. And the one important characteristic to remember about the flu is that it has these gene segments in it. Each of these is sort of like our chromosomes, how we have 23 pairs of chromosomes. Well, the flu has different segments of genes on here. And one segment might code for hemagglutinin, and another one might code for neuraminidase, and whatever BS else is going on in this flu virus. So each of these gene segments, it creates a bigger problem if you're infected with more than one flu virus. And we're going to talk about that. For the hemagglutinin and the neuraminidase, this is why we call the flu virus H1N1 or H5N5 or whatever it is based on the basic overall structure of the hemagglutinin or the neuraminidase. The hemagglutinin is the binding protein on the surface of the virus that allows it to get into the cell. The neuraminidase is an enzyme that helps basically with the virus being infectious. So it helps break down mucus. It also helps with entry into the cell, as well as it helps with budding out of the cell. It helps clip off the new budded viruses after they're making new ones. So the way that we get the different flu viruses is either through antigenic drift or antigenic shift. Antigenic drift is basically, I think of it as you're drifting along in the ocean or you're shifting yourself like with a paddle, making bigger movements. So antigenic drift, you're at the whim of the replication of the virus within the host cell. And you might just have random mutations introduced from that. This usually can cause new strains of flu to come out, but the disease won't be as serious from year to year because you'll usually have some aspect of immunity going on there. But when we have antigenic shift, we're swapping around those gene segments that were in there. I'll show you how in a second, but this antigenic shift is usually what is going to be causing the pandemics. And so antigenic drift, you're just drifting along, you're at the whim of making just random mutations. Big old changes is antigenic shift. Antigenic shift makes you say, oh shit. Also, as I remembered this is because I was talking about the slide one time before I was so free with my language in my classes. And I was talking about antigenic shift and I said antigenic shit. And I was on this slide and the pig is on here. And if you know this about pigs, they're poopy animals. They're not clean naturally. If you're out in like the wild or like in farms, you can keep them in your house and keep them clean. But other than that, these are some messy animals covered in shit, we'll say, right? So this is how I remembered this is that we got the poopy pig. The pig becomes infected with a duck flu and a human flu at the same time. The new virus that comes out of the pig has part duck and part human. This is antigenic shift. This is how we get new flu viruses that are big change viruses, not just little minor mutations. So we have reassortment of the gene segments. That is, and it happens within a host, two different viruses within the same host. And the new virus that comes out is a mixture of the two. And you have no immunity to that, and that's what leads to pandemic. All right, so this part where I was saying about some of these respiratory illnesses are more common in colder months. Here's why. Cold air dries out your mucosa and makes you more susceptible to viral infections. So the cold air can cause irritation in mucosa, and all that moisture from the mucus in your mucosa is there for a reason. And so when that gets dried out, you're actually more susceptible to disease. So when mama and daddy were telling you, oh, don't be outside in the cold for too long, you'll catch cold. The cold weather itself doesn't make you sick, but it makes you more susceptible to getting infection from all of these different diseases. So it's not completely untrue. So next time you hear people saying, oh, you can't actually get sick from being cold. No, the cold won't make you sick, but the cold will make you more susceptible to it, more likely to get sick. There's some truth there to it. How do we prevent the flu? Keep up with your flu vaccines every season. Flu vaccines can be pretty good if we get the strains that we're anticipating. Sometimes we get different ones, sometimes they mutate before we have a chance to have a vaccine for them. There is some work being done trying to develop a universal flu vaccine that shouldn't be needed to update it all the time, but that hasn't shown a lot of advancement with that. Moving on to tuberculosis or TB, also known as consumption. This is an ancient human disease. It's basically existed since humans have. It's been around for a very, very long time. After we discovered streptomycin, which was antibiotic, we had the rates decrease very significantly, but now it is a re-emerging disease. It's coming back out again due to HIV epidemics and increased drug resistance. About a third of the world's population is infected currently with tuberculosis. Whether they're having signs or symptoms or not isn't the discussion. They have it. And so we're going to talk about that in a minute. But tuberculosis is caused by the bacterium, Mycobacterium tuberculosis. And technically, tuberculosis is a syndrome because you can have symptoms and signs associated with tuberculosis. It can potentially be caused by other bacteria, but by and far, that's going to be Mycobacterium tuberculosis primarily. All right, what is tuberculosis? With Mycobacterium tuberculosis, there's an infectious dose, meaning that you only need to have a dose of 10 bacteria to get started with infection in your lungs. In primary tuberculosis, this is the initial setup of the disease in your lungs. You might have some mild signs and symptoms with primary tuberculosis, but what happens is after primary tuberculosis happens and we have these tubercles forming, it becomes dormant after that. It becomes a latent illness, sort of like with chickenpox, where it can come back out again as shingles, except when primary tuberculosis goes dormant and then it comes back out again, we call that secondary tuberculosis. That's consumption. That's when you have the serious signs and symptoms of tuberculosis. People can carry tuberculosis for years without signs or symptoms at all. So a third of the world is infected with it. Good luck with that. Here in the United States, it's much more common in immunocompromised folks, but we are seeing outbreaks more and more commonly in healthier populations. So just be aware of that. These tubercles, what's happening in the lungs here is that we have granulomas forming. And what a granuloma is when white blood cells come in and try to wall off and contain an infection. And so all the white blood cells and all the bacteria that are being killed by them and all that basically get confined to these areas. And then those cells can die. The bacteria in the middle will die because they don't have any oxygen. And these lead to necrotic lesions. We call them caseous because they look like cheese, like casein would form in a milk, the chunkiness in milk. So these are caseous lesions. They'll be semi-soft lesions that will eventually dry out and harden and become calcified. Those are tubercles that will form in the lungs and will stay in there. And you can see these tubercles in x-rays as well. So it's typically what we're going to be talking about. The bacteria, Mycobacterium tuberculosis, Mycobacterium, all of those species are acid-fast positive. So they have that wax on their outer surface, and that mycolic acid wax makes them more resistant to like drying out and being killed by like cleaning, detergents and things like that. So they're pretty resistant bacteria naturally. They are strict aerobes. They live inside of your alveolar macrophages. So that your macrophages in your lungs that are there to eat up everything as phagocytes in those regions, they come and eat up these bacteria. And the bacteria are like, thanks for giving me this new house for free. This is great. And they don't care about your phagolysosome or anything like that. They're happy to be inside of those cells and they live there and thrive there. So I don't know if you know this, but one of the top treatments for tuberculosis used to be in these sanatoriums. And so when you had TB, they'd put you in these hospitals and then like have you spend a lot of time outside because they felt like the cold, fresh air would help kill the bacteria. But these are strict aerobes, y'all. They want the air. They're happy for it because they're going to be going through aerobic respiration and they need the oxygen. So that wasn't actually helping to treat the tuberculosis at all. In any case, it could have made it worse. So tuberculosis, using the Manito PPD skin test. They'll inject a little bit of tuberculosis protein under the skin, tuberculin, which is found on the surface of the bacteria. If you have a response 48 to 72 hours later, then that is your delayed type response mediated by your CD8 cells, cytotoxic cells, because this is an inside pathogen. They live inside of your macrophages. So this is MHC1 that the macrophages will be infected inside. They'll say, I'm infected inside. On my MHC1, I've got an inside infection, and the CD8 cells can come and respond to that and try to kill them. The problem is, of course, that these bacteria are pretty good at just evading that whole process. So what happens is you will become dormant after your primary infection. It becomes dormant, and you can hold this infection in your lungs, basically not doing anything, becomes latent for years, and then it can reactivate. And this leads to severe symptoms of violent coughing, greenish or bloody sputum, low-grade fever, anorexia, weight loss, fatigue, night sweats, and chest pain. And once you have secondary tuberculosis or reactivation tuberculosis, untreated tuberculosis has a 60% mortality rate. You can treat tuberculosis with antibiotics, which we'll talk about in a moment. But again, Mycobacterium always causes this. The most common version of this is caused by Mycobacterium tuberculosis. Mycobacterium always have that mycolic acid wax on their surface. They're acid fast. Here's an image of an acid fast stain where we have that reddish pink fuchsia colored bacteria that are positive for mycolic acid. All right, it's transmitted through droplet transmission and mucus in the air. That can be suspended in the air for hours after somebody has been coughing with tuberculosis. It's pretty common all over the world, but it's more common in areas where we have close living, inadequate nutrition, lower immune system issues like what we see with HIV, poor access to medical care, previous lung damage, or just genetic factors that can make you more susceptible to it. These are some ways that you can diagnose tuberculosis. The PPD Manito skin test. IgRA is basically an immunoglobulin reaction assay. So we're using antibody antigen response. There's a PCR, acid fast staining of sputum, and chest x-rays. All right, active tuberculosis. Once you have that secondary reactivation tuberculosis and you have signs and symptoms, then we can treat you. When it's in its dormant form, it's incredibly difficult to treat. So if you have active tuberculosis, we will, your first 2 months, you'll be on rifampin, isoniazid, ethambutol, and or ethambutol, however you want to say that, and then pyrazinamide. These antibiotics will be given for a couple of months, and whichever one is working the best, the two that work the best, we will continue for another 4 to 7 months. So we are talking 6 to 9 months worth of antibiotics, and we have people that won't stick with their antibiotics for 10 days. So this is why we have drug resistance developing in this. It's really becoming an extremely huge problem right now. Moving on to pneumonia. Pneumonia is a syndrome. This is where we have inflammation inside the lower respiratory tract and the lung tissue, and then the lungs will fill with fluid from the edema from that inflammation. Then oxygen can't get into the alveoli, and you'll have people turning pale or bluish, cyanotic, we would say, because that lack of oxygen, being able to have that exchange going on in the alveoli. Usually, viral pneumonia, viral versions of this will be less severe than bacteria, but most of the time, the more serious effects are going to be caused by bacterial versions. Signs and symptoms, usually you'll start with an upper respiratory tract infection, and then you will later on have the lower respiratory tract involved. That can lead to chest pain, fever, cough, discolored sputum involved in that, and that sickly cyanotic look of lack of oxygen. Again, your alveoli and your bronchioles and things like that are going to be filling up with fluid as a result of the inflammation from the infection, the edema that results from that. Okay. This is caused by Streptococcus, the most common bacterial cause of pneumonia. especially community acquired, not from hospital exposure, but from just out and about. This is Streptococcus pneumoniae. Finally, we're back to this guy again. So Streptococcus pneumoniae, the most common cause of communally acquired pneumonia, is alpha hemolytic. We see this greenish discoloration around this bacteria. If it were to be clear, that would be beta, but because it's a greenish halo around it, that is alpha. 50% of healthy people maintain Streptococcus pneumoniae in their normal biome. So this is pretty common, but it's usually supposed to be in your upper respiratory tract. Let's say you get a cold or you get the flu or something like that, and your lower respiratory tract might become compromised. And then the Streptococcus pneumoniae can get inhaled deeper into the lungs and then lead to development of pneumonia. It is communicable, so you might not have Streptococcus pneumoniae, but maybe somebody you contact does, and then that can make you susceptible to getting this disease. Streptococcus pneumoniae has a capsule to evade phagocytosis, and it also is able to block complement action that way. There is a vaccine available for this. This is the pneumococcus that we talked about with our meningitis. And so the vaccine protects against the meningitis as well as the pneumonia. If you have a type of pneumonia that doesn't have you bedridden, if you had pneumonia, but you're still able to otherwise be walking around and be alive, you'll feel sick, but you won't be bedridden. You won't need to be going to the hospital or something like that. And that's what we call walking pneumonia or atypical pneumonia. And so when you have pneumonia like that, it's usually caused by Mycoplasma pneumoniae, which is a bacteria that lacks a cell wall. That's what the mycoplasma is. Remember if you spill a cup of plasma? Remember all that BS from so long ago now? These are mycoplasma. We also have pneumonia that can be caused by Legionella pneumophila. So this is Legionnaire's disease. So in '76, there was the American Legion Convention, which is some veterans getting together, some old guys, and they ended up getting pneumonia as a result. And what happened was the cooling tanks of the building, you remember those big old like cooling air conditioner things that have like the water running down the sides of them for bigger buildings. Well, that was contaminated with this bacteria, Legionella pneumophila, which lives in water environments. And then that air conditioner was just spreading it throughout the air. People with normal, healthy immune systems aren't as susceptible to this. So this is not as common, but it's one of the causes of sick building disease. And so a sick building disease or syndrome is basically whenever like the building has something wrong that can lead to you getting sick. So this would include things like toxic mold and stuff like that. Next, we have Histoplasma capsulatum. This histoplasmosis is associated, this is something that contaminates like bat droppings and stuff. So this is also known as spelunker's disease, but it can be found in other areas as well. So this leads to a type of pneumonia normally associated with either people that are exposed to bat droppings or to people who have low immune systems for whatever reason, being elderly or having AIDS. One that is very commonly associated with AIDS is pneumocystis gyrovecii. This is a fungal infection that can lead to pneumonia. Usually it's a pretty normal biota in healthy people, and this is therefore more commonly associated with AIDS. And so if you're having a pneumonia caused by this, you probably have AIDS. So it's one of the like defining features that, hey, you have pneumonia caused by the fungus, and probably you got AIDS. We need to check that. All right, our healthcare associated pneumonias. Healthcare associated pneumonia is about 1% of all hospitalized people who are staying overnight. About 1% of them will develop pneumonia. This is often associated with ventilation equipment. So this could be intubation, endotracheal or tracheostomy tubes are more commonly associated with this and usually related to not cleaning the ventilation equipment effectively or using sterile or properly treated equipment. Patients that get pneumonia in a hospital, a 30 to 50% mortality rate. I mean, this is like Ebola level stuff. You get pneumonia in a hospital, might as well be working on your will if you're even conscious to deal with that, right? So a lot of these patients aren't. And so it's usually why this would be leading to an infection. So if you get healthcare associated pneumonia, which is an HAI, a hospital associated infection, the usual causative agents are just bacteria that are around. This would be MRSA, Klebsiella pneumoniae. So these three, all of this actually, from Klebsiella pneumoniae down to Acinetobacter. All of these are just normal parts of people's biome and the environment. All of them. They're just all over the place. So these are bacteria that don't belong in the respiratory tract or that could potentially be contaminating the upper respiratory tract just as part of the normal biome that have moved deeper down. Most of the time, this is going to be polymicrobial, meaning there's more than one bacteria involved in it. It's usually an overgrowth of a normal common bacteria from the environment. How do we deal with this? Most are due to respiration from fluids from the upper tract while being on ventilator equipment or being unable to move, for being unconscious, for whatever that is from. The best way to prevent this would be elevating the patient's head at a 30 to 45-degree angle to prevent aspiration, and encouraging deep breathing and frequent coughing for those patients who are conscious. Proper care of ventilation and respiratory equipment is key, but this is probably the number one biggest problem with all this, is maintaining proper ventilation equipment. And I mean, I had students that were dealing with a patient that had a respiratory tract infection last semester, and they would bring me pictures like, we just changed out their ventilation tubes and things like that just 2 days ago, and now look at the fluid that we got out of their lungs. And it was like disgusting. I mean, thick brown. And yeah, so sometimes, especially when your patients have immune disorders, not just autoimmune, but any immune disorders, or are already infected with something, and their immune system is weak because they've been through trauma or disease or something, they're going to be way more likely to have these things. So this is actually not uncommon. To get a pneumonia, again, 1% of all hospitalized patients will have this. 30 to 50% dying. I mean, it's a pretty serious thing. Something to be aware of. Next, hantavirus pulmonary syndrome. So hantavirus is a type of virus called a Bunya virus, and it is maintained in rodent populations yet again. So this is a zoonotic disease, and it's spread through the feces, urine, and saliva that get dried up and found around the house if you have mice. And then when you go to sweep or clean up, it gets brought into the air, and you inhale it, and then you get the virus. It can cause severe kidney damage and hemorrhagic fever in other parts of the world, but here it seems to be mostly associated with pulmonary disease. And it's a pretty serious disease. It's an emerging disease in the Southwest America, in the Four Corners region, where we have these drier, arid climates, where we have these types of mice that carry it. It started being discovered in 1993, so it hasn't been around very long, which is why we call it emerging. It has a mortality rate of 33%. It's pretty high. The prodrome, you're going to feel sick. You're going to have a respiratory disease. You're going to be feeling sick. So that's the prodrome, the first part of this. But then eventually, this can lead to more severe pulmonary edema and acute respiratory distress, having difficulties breathing and things like that. And that lack of oxygen and the cyanotic effects can cause brain damage and coma eventually, and that's what you would be dying from. Transmission, the airborne dust when disturbing the urine, feces, or dried saliva associated with deer mice. So normal deer mice, this is not anything particularly strange. We have increased incidence in the United States, west of the Mississippi primarily, where we have these more dry and arid climates where these animals are found. We can diagnose this with detection of antibody to the virus or with PCR, but there's no treatment other than supportive care for this viral infection. Here are some incidences of distribution of hantavirus cases, and then more commonly in California, Arizona, New Mexico, Colorado, and over here, but we have had cases even here in the in Oklahoma and Texas.